The topic for this lecture is the musculoskeletal system. We're going to be fairly focused in this system. So we're going to talk about arthritis and being sure that you can identify the difference between osteoarthritis and inflammatory pathologies of arthritis. We'll talk about osteoporosis. And then we'll also, in children, talk about both the etiology and the manifestations of muscular dystrophy, especially focusing on Duchenne muscular dystrophy, because that's the most common type. And then we'll end with summarizing the effects of aging on the musculoskeletal system. Let's start then thinking about arthritis. There are three types of arthritis we'll discuss. We'll talk about spondylitis, osteoarthritis, and rheumatoid arthritis. And we'll spend most of our time on osteo and rheumatoid arthritis. But spondylitis is another form of arthritis that you will see in adults. You don't see this in children, but you will see this in primary care and may also see this in acute care, not as an acute illness, but as a comorbid condition of some of your older patients. Spondylitis, like any arthritis, is an inflammatory process. And this inflammation is due to both T cells and cytokines. The most common cytokines that have been associated with spondylitis include interleukin 1, 6, and 18. So a fairly small number, but as we know, we're learning more and more about the interleukins and their role as inflammatory cytokines. What happens with spondylitis is that there is, and the result of the T cell, the inflammatory response involving the T cells and the cytokines, is that this leads to a fibrotic state, ossification, and then fusion within the spine and the sacroiliac joints. And this fusion is due to uncontrolled bone formation. What's characteristic of this spondylitis is that this uncontrolled bone formation, and part of what we see are the growth of osteophytes. Osteophytes are bony outgrowths, essentially little spurs, that form along the joint margins. As a result of the inflammatory process and the ossification, these bony outgrowths, the osteophytes, cause the spurs to thicken, and these thickened spurs that are around the joint margins lead to decreased mobility and a great deal of stiffness. Now, in some cases, this will cause what we call ankylosing spondylitis. Ankylosing spondylitis specifically involves the spine and is, especially at the base of the spine, and leads to manifestations of chronic pain and fusion of the vertebral bodies. The reason I mention this one specifically is this is one of the things you might look for in an individual with chronic low back pain, because on average, individuals with ankylosing spondylitis have had chronic low back pain about 7 to 8 years before they are actually diagnosed. In addition, very interestingly, individuals with ankylosing spondylitis have an increased incidence of kidney stones as well as inflammatory bowel disease. Now, so where does this inflammatory process come from? We do believe that there is, to some degree, a genetic association, and it's most likely on the HLA-B gene variations. And remember, the HLA system plays genes play major roles in the immune system and immune system function. With osteoarthritis, we see the loss and damage of weight-bearing synovial joints. So this is a key feature of osteoarthritis. We especially see this in articular cartilage as well as the joint capsule in both the central as well as the peripheral joints. So we look for this loss and damage in these synovial joints in the hips, the hands, the knees, as well as the spine. Rheumatoid arthritis, unlike osteoarthritis, is an autoimmune inflammatory disease. As a result of the rheumatoid arthritis inflammatory process, this results in joint swelling, tenderness, and actually joint destruction at the synovial membrane itself. Let's take a closer look, though, at both osteoarthritis and rheumatoid arthritis. So osteoarthritis is characterized specifically by the loss of articular cartilage. As we age, we have fewer proteoglycans in our cartilage, as well as osteoarthritis will occur or has a higher incidence in any process that damages the cartilage directly. So that's why you'll see this in individuals who may engage in high impact sports that could damage the cartilage. But let's go back to this idea of the proteoglycans. We know that the cartilage is a matrix, and this matrix is under the influence of the work of the proteoglycans as well as the chondrocytes. Chondrocytes are the cells in the cartilage. Proteoglycans are part of our extracellular matrix, and in the joints, these proteoglycans assist with healing and repair. So that makes sense then that when you have damage to that cartilage, and as we age, you have fewer of those proteoglycans present in the cartilage. And remember, proteoglycans are what we need in that extracellular matrix to assist in healing when we do have any injury or any erosion. So what happens in the articular cartilage is the cartilage actually flakes off and fissures begin to develop, causing thinning of the cartilage. With the loss of that cartilage, the bone has lost its protection. And with the unprotected bone, cysts begin to develop, and they actually break through the cartilage in the joint cavity. Now remember those osteophytes that we talked about, these bony spurs. These osteophytes in osteoarthritis actually grow outward and alter the bone as well as the joint anatomy. And this is what you'll frequently see in the hands of someone who has osteoarthritis. So the way these look is if you look at these osteophytes, these outgrowths, you'll see them in the distal phalanx, and those are called Heberdine's nodes, or if they're in the medial phalangeal joint, those are called Bouchard's nodes. Now, you're going to learn this in your assessment course, but I think understanding that we can actually see these, and where we see them, they have a special name, the Heberdine's in the distal, the Bouchard's in the medial phalanx, tells you that we know something about these. Now, because of these osteophytes, remember these outgrowths, these bony spurs, altering that bone as well as the joint anatomy, this causes irritation of that synovial membrane. That synovial membrane is our protection. This then leads to synovitis because of the irritation, as well as effusion, which means a movement of fluid into that area. That's why when you touch someone that has a very osteoarthritic knee or finger joints, they feel kind of boggy, kind of squishy. Now, this whole process is associated with inflammation and with that inflammation, as we talked about, enzyme destruction of the proteoglycans and the collagen of that articular cartilage. In addition, you'll see cartilage-degrading enzymes as well as apoptosis of the chondrocytes. Remember, chondrocytes are the cells that are in the cartilage itself. And these are actually the cells that produce that collagen matrix, so important to that articular cartilage. When you have cartilage-degrading enzymes as well as death of the cells that actually make the cartilage, the chondrocytes, that's going to lead to destruction of the cartilage and the collagen, and therefore the end result of this is decreased strength. So what are the key manifestations then of osteoarthritis? Certainly one of the most important thing is pain and stiffness. Now, as that goes longer, it makes sense so that there would also be decreased strength within those joints that are involved as well. But when we look at the pain and stiffness, there is no specific relationship to the time of day that this pain and stiffness occurs. We also know that the pain increases with use and decreases with rest. And those are key manifestations, that the pain and stiffness don't have a relationship with the time of day, and that the pain is worsened with use and decreased with rest. And of course that becomes issues with immobility or lack of mobility in an individual that has significant osteoarthritis. You can see the negative sequela there. So how is that different then from rheumatoid arthritis? Rheumatoid arthritis, as we identified earlier, is an inflammatory process. And indeed, rheumatoid arthritis is characterized by significantly more inflammation than osteoarthritis. So in rheumatoid arthritis, this process begins with cytokine-related inflammation in the synovial membrane. This inflammation progresses to the articular cartilage, the joint capsules, as well as the ligaments and the tendons of the joint. So that's a big difference then from osteoarthritis, isn't it? Because we didn't talk about ligament and tendon involvement, inflammatory involvement, with osteoarthritis. When we think about what actually causes this rheumatoid arthritis, we have a pretty positive sense that there are some genetic influences, probably again in that HLA gene matrix. There have been T cell abnormalities as well as inflammatory cytokines and autoantibody formation implicated. So what happens in this disorder, this inflammatory cytokine-related disorder, is that the inflammation causes modification of arginine to citrulline. And as a result, then the body recognizes citrulline as an antigen. And we can actually test for antibodies against the citrulinated proteins. And this is probably one of the most specific and sensitive tests for rheumatoid arthritis. It is estimated to be about 90% specific, excuse me. So we have this inflammatory response. Arginine is being modified to citrulline, and then the body recognizes this citrulline as an antigen and builds antibody to it. The synovium becomes very thick and is replaced by granulated tissue or pannus. Pannus is an abnormal layer of fibrovascular or granulation tissue. Now, because of this thickened synovium and the laydown of this pannus, there are more stimulation of the phagocytes. And those phagocytes then stimulate even more enzymes, and that increased enzyme activity causes additional breakdown of the synovial tissue as well as the cartilage. In the immune system, we see the activation in both the T and the B lymphocytes, and as a result, you'll see an elevation of rheumatoid factors. Until the discovery of the autoantibodies against the citrulinated proteins, rheumatoid factor was pretty much the most specific test we had. Now, the good thing about rheumatoid factor as a manifestation or a lab test that we can run is that it is pretty sensitive. However, it's only about 50% specific to rheumatoid arthritis itself, because it is a rheumatoid factor, not a rheumatoid arthritis factor. So with this immune system activation and the release of the rheumatoid factors, even more enzymes are being released, and this then continues to perpetuate this inflammatory response. The end result of the inflammation and the immune responses include swelling, thickening of the articular membranes, vascular changes due to both local hypoxia as well as acidosis, which then increases additional enzyme destruction. This if you take that all the way to the end, then you would have the develop of fibrin and fibrous tissue as well. So where do you see this then? Well, you see this in the hands and the wrists as well as in the larger joints. When you look at the hands of someone who has rheumatoid arthritis, one of the things you'll see are nodules in the knuckles because of this inflammatory response, the proximal interphalanges because of this inflammatory process. You will see it affects both hands, wrists, as well as the larger joints. But when you look at this in the hands and wrists, this is the individual who has a lot of ulnar deviation and would have a lot of deviation of even the individual finger joints as well. Now, characteristically, this causes a symmetric joint swelling because of these exudates. Remember, this is systemic. You won't necessarily see symmetrical joints being involved in osteoarthritis. So you could have someone who has one knee affected but not another, one hand affected but not another in osteoarthritis. So again, a distinguishing factor. Another distinguishing factor is the pain of rheumatoid arthritis. The pain characteristics of rheumatoid arthritis, first off, the pain is not related to increased use, nor does it decrease with rest. So there's a characteristic difference with osteoarthritis. In addition, in rheumatoid arthritis, the pain is greater in the morning on rising and then begins to decrease. So again, the pain characteristics, when you differentiate between rheumatoid arthritis and osteoarthritis, are different, as well as the pathology and the presentations. Let's move then from arthritis to osteoporosis. When we look at osteoporosis, strictly defined, osteoporosis is a decrease in the bone mass or the decrease in density. And this bone mass or density is decreased although the mineralization of bone remains intact. But because the density is decreased, this results in a decreased trabecular as well as cortical bone integrity. So when we look at, remember that you have trabecular and cortical bone. Trabecular bone is about 15% of your bone. Cortical is about 85% of your bone. Both of these are mesh-like structures. However, trabecular bone, that meshwork of trabecular bone, is less complex, doesn't have concentric layers, and instead of layers, it has plates. And this tends to be the spongier bone at or near the epiphyses. Cortical bone also has a mesh-like structure like trabecular, but it is much more organized, solid, and stronger with concentric layers. So there's a difference between your cortical bone and your trabecular bone. Most of your bone is cortical, but what happens is, again, this trabecular, this spongier bone, loses some of its structural integrity, and this cortical bone becomes porous, thinner, and as a result is weaker bone. So that's why when you look at osteoporosis, you think about bone mass or bone density, even though the mineralization processes may be are pretty much intact. When we think about osteoporosis and the pathophysiologies and the risk factors, certainly we have both primary as well as secondary. Primary osteoporosis is the osteoporosis associated with aging. Now, we tend to think about this in postmenopausal women especially, but remember, osteoporosis also occurs as men age. We're going to talk more about that. We also know that osteoporosis can be secondary to other pathologies. So it may be due to other diseases. What childhood disease did we talk about that can lead to osteoporosis? Yes, cystic fibrosis. Because of the changes in pancreatic enzymes reaching the small intestine, they aren't able to absorb those fat-soluble vitamins A, D, E, and K. In inflammatory bowel disease, specifically Crohn's disease, you may also see a higher incidence of osteoporosis depending on how much of the small intestine is either affected by the Crohn's disease, or if someone has had a lot of the small intestine resected and they don't have a lot of absorptive surface for those fat-soluble vitamins in the small intestine. We know that there are a number of medicines that that are associated with osteoporosis. The two that immediately come to mind include lithium and dilantin. Individuals who abuse alcohol are more likely to have osteoporosis, partly due to poor intake of calcium, but also because of altered nutrition and other altered nutrition, and individuals who abuse tobacco have a higher incidence of osteoporosis as well. When we think about osteoporosis, we need to remember that it affects all parts of our skeleton, both the axial as well as the appendicular, so it's going to be in both the spine and the vertebra, as well as our extremities, our shoulders, our pelvis. I don't expect you to memorize the World Health Organization definition, but I do think it's important that you look at the significant decrease in bone mass from normal. Finally, before we talk about the pathophysiology of osteoporosis, is osteopenia. Osteopenia is that sort of gray area between normal bone mass and osteoporosis level bone mass. So let's take a look at osteoporosis in detail. The basic issue at its core, the issue with osteoporosis, is that old bone is being resorbed faster than new bone is being made. So old bone is being resorbed at a faster rate than new bone is being put down. As a result, then, the bone becomes increasingly thin, porous, and less dense. So when resorption is greater than formation, you have a decrease both in quantity, which is the density, as well as quality of the bone itself. Now, if you have not taken the opportunity to review the Word document that I posted along with the slides, it might be a good idea to stop the tape now and read that document, because that kind of stepped us through this process in another way. So I just wanted to try to give you a sense of some of that. So let's talk about osteoporosis. Osteoclasts and osteoblasts are both essential not only to osteoporosis but to good bone health. Remember that osteoblasts are your builders, osteoclasts are your removers. Osteoclasts are especially important in the proliferation, the differentiation, the fusion, and the activation processes of our bone. So that as a result, then, osteoclasts are critical to the way we remodel bone throughout our life. So how then does aging in both women and men play into osteoporosis? We know that as we get older, osteoporosis, while it is not a given that this is going to happen as we get older, it is more likely to occur as we get older. And we especially are concerned with the spine and the femoral neck. And again, both the quantity, the density, and the quality of bone is affected. So what happens postmenopausal? In postmenopausal women, you have decreased estrogen. We know that. As a result of, at the same time rather, with the decreased estrogen, we know that as we get older, we have greater oxidative stress as part of our aging process, as well as the accumulation or the probability of radical oxygen species developing. Now, when you have decreased estrogen and you have more oxidative stress, That then leads in higher bone turnover. So osteoclast, that remodeling, is overwhelming osteoblast activity. With this increased turnover, there's the development of pro-inflammatory cytokines. With these pro-inflammatory cytokines, there is a decrease in osteoprotegerin as well as insulin-like growth factors, both of which are critical in terms of bone health in women and also in men. Now, we know that this bone resorption occurs before menopause, and although it increases in the first few years following menopause, it continues through our 50s. It might surprise you to remember that our peak bone mass occurs right around the age of 30 years. Now, what about men? We know that men also manifest this high bone turnover disease. But men tend to manifest later in life simply because they started off with an increase in bone mass as compared to women. At the same time, as we get older, both men and women, we have less type 1 collagen, and that type 1 collagen is a player in bone density. We know that estrogen has protective effects. We're going to talk about that more. We just talked about that postmenopause. And we also know that we have dietary issues that may affect our bone health as we get older. So as we get older, we are aware that calcium absorption is decreased with age. So we may, or we may take in less dietary calcium as well as vitamin D. Well, if we don't take in enough, and or if we have poor absorption of calcium and vitamin D, that then sets us up to develop osteoporosis. Remember that fat-soluble vitamins A, D, E, and K require fat in the diet and require small intestine function. We also know that in some cases, as we age, we do less exercise, especially weight-bearing and active exercise, and that's important to bone health. We may have a family history of osteoporosis, and we may have a low BMI. Low BMI has been associated with osteoporosis. Very high BMIs have been associated with osteoarthritis. We also know that with osteoporosis, we have to think about hormones as well as trace minerals. So hormones we would think about would be the parathyroid hormone. Remember, parathyroid hormone is important in phosphorus and calcium metabolism. Thyroid hormone is critical for corticotropin, again, bone health. And cortisol is an anabolic or growth-related hormone, as well as we talked about growth hormone. Trace minerals that are important in our bone health include zinc, copper, and manganese. So when you think about osteoporosis, we focused so much in our discussion of osteoporosis most of the time on calcium and vitamin D, but we have to remember that we also have to think about hormones that play into bone health, as well as those trace minerals that are also important to our bone. So I'm not done with you yet on this osteoporosis. Let's go back and let's talk about some of those issues that are related to reactive oxygen species as well as oxidative stress, because they are key issues for osteoporosis. In osteoporosis, and when we think about the pathophysiology, and we talked about that there was more oxidative stress as well as reactive oxygen species as part of this pathophysiology. We know that reactive oxygen species are signals for osteocytes, osteoclasts, and osteoblasts. So when these levels are increased, oxidative stress leads to bone mass as well as bone strength loss. So how does all this happen? Well, we know that we have oxidative stress. We also know that part of this process is somewhat of a complicated process, but it starts with rankle, and rankle is a nuclear factor ligand that comes from the osteoblasts, and it's actually needed to develop osteoclasts. So as a result, there's increased bone resorption due to the increased development of osteoclasts and decreased clast apoptosis. Because what this rankle does is it activates rank, and it activates these rank receptors on the osteoclasts, therefore suppressing apoptosis. When you suppress apoptosis, when this rankle activates the rank receptor on the clasts and suppresses apoptosis, you have an activation and prolongation of osteoclast survival. So you've got breakdown greater than production. Now, how does aging once again play into this? Osteoprotegerin blocks the effects of this rankle. So if I can block the effects of rankle, there's no activation of rank. If I don't have rank, I don't keep those osteoclasts surviving. I actually decrease osteoclasts. So osteoprotegerin blocks the effects of rankle. Without rankle, there's no rank. If I don't activate the rank, then I'm not going to activate as many or prolong the osteoclast survival. So where's the key there? Next piece. Estrogen stimulates the osteoprotegerin. So let's put this all together. What happens in menopause? So in menopause, you have less estrogen, right? As a result of having less estrogen, you have an increase in rankle because you've lost that osteoprotegerin blocking effect. So you have increased rankle, which then leads to rank. That rank increases the formation of osteoclasts and decreases their programmed cell death. At the same time, what happens in menopause, you also have the lack of estrogen to activate these ERKs. ERKs, or estrogen receptor kinases, is needed for to decrease the apoptosis of blasts and increases the apoptosis of clasts. So it's not balanced. So let me be sure that I said that clearly. ERKs, these extracellular kinases, decreases apoptosis of the blasts and increase apoptosis of the clasts. So if I don't have estrogen to help me with these ERKs, as that estrogen decreases, you have fewer ERKs, therefore your blasts are undergoing apoptosis, and your clasts are not undergoing apoptosis. So it's out of balance. Now, the end result is going to depend on how long the ERKs are actually active within that nucleus. And remember, this is being controlled by hormones, cytokines, and our cellular environment. Estrogen decreases in women and men as we age. And remember, that's our stimulus for the osteoprotegerin. Please let me know if you have any questions about this, because I know that there are a number of different steps here, but I hope between going through this verbally as well as that handout, that Word document handout, is helpful. So let's turn our attention from adults and let's talk about kids for just a little bit. One of the most common things we'll see in the musculoskeletal system with children is muscular dystrophy. Now, muscular dystrophy itself is actually a very large group of disorders. all of which affect voluntary muscle fibers. And certainly Duchenne muscular dystrophy is one of these group of 9 dystrophies. Duchenne muscular dystrophy is primarily a genetic disease. It affects males, and the most common is an X-linked recessive genetic disease. The genetic defect in Duchenne muscular dystrophy is that there's a lack of the gene that produces dystrophin. Now, sometimes the gene can be there can be a complete lack of dystrophin, or there may be a significant decrease in the amount of dystrophin that is being produced. Duchenne muscular dystrophy, as I said, is one of a group of many muscular dystrophies involving the voluntary muscle fibers. So let's go back and let's take a look at dystrophin. Dystrophin is a substance needed to anchor the actin cytoskeleton to the basement membrane of our skeletal muscle fibers. So physiologically, that's what dystrophin does. It's part of our anchoring system in our skeletal muscle fibers. So without dystrophin, or without sufficient dystrophin, this means that these skeletal muscle fibers are not well anchored. And as a result, they have the ability to tear away from their attachments in the basement membrane during muscular contraction. When those skeletal muscle fibers, those anchoring fibers, are torn away because of the lack of dystrophin, with that tearing, their cellular integrity is altered. Well, because of the alteration in cellular integrity, calcium floods into those cells. As we know, calcium flooding into cells frequently causes cell death, and as a result, the fibers then become necrotic. With necrotic muscle cell fibers, then, the muscles themselves begin to degenerate. So what's happening here then is that dystrophin, which is necessary for anchoring, as we are young and throughout our lives, we have the ability to regenerate our muscle cells. However, what's happening is that the need for regenerating these fibers is being overwhelmed by the body's ability to keep up with the cell death, because of the rapid cell death that's occurring in Duchenne muscular dystrophy. So how then would this manifest? Well, we know that the manifestations are progressive. Most children with Duchenne muscular dystrophy are diagnosed by the age of 3 years. The muscles that are especially affected are those that are present in the hips, and the gastrocnemius and the quadriceps, in addition to the shoulders. Now, what's interesting though is hips, quadriceps, and especially gastrocnemius muscles are generally affected first. Shoulders may occur a little bit later. As I said, this is a rapidly progressive disorder, and generally what parents notice is that the child has a very slow motor development. So they're not sitting, standing, or walking when you usually expect those sorts of milestones to be occurring. And remember, this is characterized because of the lack of dystrophin and those fibers being torn away during muscle contraction. This is why you don't see it until the child is actually using those muscles. It's characterized by progressive muscle weakness as well as muscle wasting. Now, we know that because of the although we talked about the effect on skeletal muscles. The long-term effects can also affect both the cardiac muscle as well as commonly the respiratory muscles. You'll see decreased respiratory function and the increased risk as a result of that of upper respiratory infection. Some children will develop a significant kyphosis because of the skeletal muscle death and the degeneration of muscles. Until recently, it was difficult for a child with Duchenne muscular dystrophy to reach adulthood. And the average age was around 20 or thereabouts. However, with new therapies, we do have children that are at least currently living into early adulthood, and I think we can see that age range continuing to expand as we find more and more treatments for this genetic disorder. Remember, X-linked inheritance, it's recessive, but because it's X-linked, primarily affects males, and it's due to a lack of dystrophin. Let's end our discussion with talking about the effects of aging, part of which will we review, but some of which will also be a bit newer. We've talked a lot about the effects of aging on the bones as well as the joints. We know that as we get older, because of the less bone mass and less that decreased density, as well as physiologic slower remodeling and mineralization, the bones can become and do become more brittle, therefore more prone to fracture. In the joints, we talked about the changes in the cartilage, the becoming more likely to be break down, more fragile, may even calcify. Remember those proteoglycans? And as we get older, we produce fewer proteoglycans. So what happens in the muscles? There are two important things that can occur in aging in the muscles. One of these is certainly related to aging, and that's mitochondrial dysfunction. And that mitochondrial dysfunction may be due to repeated oxidative stress. We know that the longer we live, the more we are likely to be exposed to oxidative stress and the potential damages of oxidative stress. We also see something in the effects of aging called sarcopenia. We've known this has occurred for quite some time, but actually elucidating the pathophysiology of sarcopenia is more recent than we would have thought or anticipated. So what we're seeing with sarcopenia is a decrease in the muscle bulk as well as strength, especially the type 2 fibers. We know that as we get older, we have less growth hormone, testosterone, and insulin-like growth factor, all of which are important to our muscle growth. We begin to lose our muscle mass as well as our bone mass in our 30s. In addition, we know that physical inactivity can also facilitate a decrease in the muscle bulk as well as strength. And this decreased muscle bulk and strength accelerates into our mid-70s. And as a result, we see this as causing an increased occurrence of frailty, falls, and fractures as we age. And sarcopenia is one of the things we talk a lot about in frail elders. Now, we talked about this being especially decreasing the strength of our type 2 fibers. Remember, you have type 1 and type 2 muscle fibers. Type 1 fibers have a lot more mitochondria than type 2 fibers, and these are the ones we lose for long duration activity. The muscles in our back and in our legs, and they store energy in triglycerides. So type 1 muscle fibers are not affected by as much by sarcopenia as the type 2. Type 2 fibers have fewer mitochondria, and those are the ones we use for short duration contraction. So these are going to predominate in our arms, our hands, and we produce a less powerful contraction, and they are easier to fatigue. They use energy quickly, and they don't have a great way to store energy for later use because they have fewer mitochondria. So that's why this sarcopenia becomes very important, especially in the arms and the hands, easier fatigue, those type 2 collagen fibers. The other thing that happens in sarcopenia is that there are fewer satellite cells. Satellite cells are those cells that are between the sarcolemma and the basement membrane. What the satellite cells is assists our ability in that cell cycle and the proliferation, differentiation of the myoblasts. And so as we have fewer of these satellite cells, we have a decreased ability to proliferate and differentiate of our myoblasts to become mature cells. And then last but not least is the shortening of our telomeres. Remember way back when we talked about genetics, and I think we talked about telomeres, and these are the little caps at the end of our DNA strands that protect our DNA from deterioration. As we get older, those telomeres, those little caps, become shortened, and when they become short, cell division is actually beginning to be blocked. Therefore, we stop growing and we enter cellular old age and therefore apoptosis. So lots of things are happening in our muscles as we get older. Now certainly we talked about arthritis, osteoarthritis being more likely as we get older, and osteoporosis being more likely as we get older. But don't forget that when we think about musculoskeletal, it's not only about our bones and our joints, it's also about our muscles and the way our muscles also change as we age. So we know that musculoskeletal pathologies do occur across the lifespan, although, as we've talked about, a lot more common with age. Arthritis is descriptive, and although arthritis has an inflammatory component, it's not equally present. So remember, different etiologies of spondylitis versus rheumatoid arthritis versus osteoarthritis, and it's important to be able to characterize the differences. Osteoporosis, even though we often think of it as an eventual effect of aging in women, occurs in men as well, although it may occur later simply because men start off with a higher bone density or a bone mass. And then the last thing, and I didn't put it on the slide, but let's not forget kids. Let's not forget that the most common muscular disorder in children is muscular dystrophy. So we want to be alert for that, and generally it's going to manifest by the age of 3 in children. I appreciate your attention as you have looked through this. We talk a lot about osteoporosis, and hopefully you've learned a few new things about osteoporosis as well. Let me know if you have any questions.